You're watching the Physio channel and we're about to do a basic knee assessment. So let's get started. We have here a real patient with right knee pain and we're going to go through an assessment. So some of the key things that I'm interested in before I physically assess the knee would include: was the injury caused by sudden trauma like a twist or a fall, or was it more of a gradual, sneaky onset, or perhaps just unknown? Okay, thank you. So gradual onset, but a recent worsening of the symptoms in relation to kneeling down. But there's definitely a backstory and quite a long history there of something been going on for a while. So we may be looking at perhaps a more acute, fresh problem and also a longer standing background problem as well. So let's have a think about what else we want to know. We want to know if there are any key symptoms present, and these would include things such as the knee locking.
It has locked, and there has been time recently, very recently, when I've actually had to move it to get in the car or out the car. It won't move itself. And the spring has gone, like when I get up, it won't push me up. It's too much pain to push me up, so I have to pull myself up.
Okay, so it sounds like there's been some form of locking or possibly stiffening up, which we'll look at in a bit more depth. Has it been giving way at all? Okay, so occasional giving way, but that doesn't sound like that's a big issue for the patient. We asked about locking, and then you also kind of described what sounded a bit like it's been stiffening up. So would you say it's been stiffening up as well as locking, or how would you describe the...
No, more stiffening up, I think, that I've had to actually move it.
Okay, so stiffening up, and you'll often find that patients will take the question of does it lock and answer it with yes, but what they often mean is that the knee stiffens up rather than actually mechanically locks or blocks into place. So it's always good to get clarification on that. And of course we will ask about swelling. So does the knee swell or has it swollen?
It has swollen, but that was with the DVT.
Okay.
The whole knee went up.
Okay, so a bit of new information there.
Yeah.
The knee did swell, but there is a history here of a DVT a few weeks ago, which has now been undergoing treatment for some time. But that swelling was around the back of the knee, and this pain was there before and is a very different thing. So that was some new information that isn't going to affect our assessment today, but of course it's an important medical thing to pick up on with patients presenting with lower limb pain. So it's also important to understand, what does the person attached to the knee really think about it? We can describe this as the lived experience. What are their thoughts? They might be worried about the likely diagnosis, for example.
Right. Well, I know I'm getting old and things wear out, but I want to know if I put up with it and live with it, or if there's something I can do to stop it getting worse or to improve it.
Okay, so that sounds positive. It sounds like an assessment will be a helpful guide for the patient, and they certainly haven't given up on themselves and given up on the physical ability of their knee. We also know from previous assessments that the patient is very active and is probably looking for some reassurance to continue with that activity. So next, I want to know, has their behaviour changed? They may have stopped cycling or walking the dog and doing other things that they enjoy. Okay. So keeping active, doing things they enjoy, but some adaptations are in place in order to cope with the knee pain or adapt to it. I also want to know about their feelings, emotions, and whether they are, for example, angry, anxious, or perhaps it's lowered their mood. Now, I may not ask the patient about this directly. I tend to pick up these things more so in general conversation during the assessment. But however I detect them, it's important to make a note of them and perhaps discuss them further, because as we said, it's the lived experience for the patient. It's what the knee pain means to them. So making a note of these things is important to try and understand what the patient is really going through. Next, you're going to need to collect some general medical information, such as medical history and current medications, to build a picture of your patient's general health, and if they have any conditions that may limit your treatment options. Now, let's have a look at the active assessment. So we start by looking at the way the patient walks, perhaps just the way they walk into the clinic. And this, of course, is their gait pattern. So with somebody with a bad knee, you may just detect that they have got a painful walk or an antalgic gait. But the sort of things to look out for are perhaps they're walking without bending their knee or restricting the bend. So a stiff leg walk, and that might be with a straight leg. Sometimes patients will lock their knee into slight flexion and walk with that kind of awkward gait pattern, which of course reduces the pain, but is not a way to be kind of continuing, as it can sometimes cause compensatory issues, and it uses up a lot more energy to walk with a limp as well. They might limit the weight bearing by shortening how long they load the leg, so they'll be taking shorter steps on that side. I'll demonstrate that. So it's an important thing to look at. Straight away you can see whether it's affecting their day-to-day life as to whether they have a limp or not, and if they are limping to any degree, you can make a note of what they're doing, and then hopefully after you've helped them you can reassess and see that things are different. So yes, gait assessment, you can pick up a lot of information about that. Right, moving on. You can then assess a squat looking for range of motion and any offloading, and of course if the patient's reporting any pain. Okay, so significant pain with that one on the right hand side, and the patient doesn't like doing that movement, so that's probably not going to be one of the best exercises to give them for rehabilitation. It's possible perhaps to also suggest looking at a one-leg squat as well. So could you put your hand on the wall for balance and stand on that right leg and just see if you can bend a bit and take a bit of weight through that. Okay, so possible, a bit of weight going through that right leg, and for some patients that might be a suitable assessment, for others it might be too much overload, but a one-leg squat is a great way of testing general lower limb strength and control. Next, let's pop the patient on the couch and get ready for some joint stress tests. So firstly, we're going to ask them to actively straighten their knee. Okay, so looks good. And then we'll ask them to actively bend their knee and use their hands to pull the knee back into as much flexion as you can. Okay.
It's beginning to hurt.
Okay, so beginning to hurt, but as you can see, there's excellent range of motion there, so it doesn't look like there's a mechanical limit of the range. So we seem to have full range of motion, and there's a willingness to perform that movement. The patient isn't cautious about doing that. They were cautious about going down into the squat movement, but not about this offloaded, more kind of active, passive assisted. So that seems to be a good thing. Just one point to make, when you're testing knee flexion, of course, if the patient's had a knee replacement, then the prosthesis is often limited to around 90 degrees or so. So you'd expect less flexion with a knee replacement prosthetic knee. So next we're going to have a look at some passive tests to stress the ligaments around the knee. And here's a selection of tests that you can do to quickly assess the knee joint. So to begin with, full flexion should lead to a soft end feel as the calf approximates up towards the hamstrings there. So that should be a soft end feel at the end of range. Moving into extension, the knee should drop into extension with a hard end feel as the joint locks into position. And sometimes there's a bit of hyperextension, or perhaps quite a lot of hyperextension in some cases. However, with this patient's knee, it's going into extension, as you can see clearly on the camera, but it does feel a little bit springy. It's not so much of a kind of bony end feel. It feels there's a bit of a spring there. So if there is a bit of springiness, sometimes that can indicate that there's something in the way. And of course, the most obvious thing is going to be some meniscal tissue. So there may be a little bit of disruption of the meniscus, which is causing that problem. Too early to decide yet, but that's one piece of information we'll keep in mind. So when the knee is flexed, it can rotate. And this rarely causes problems when you do it like this. But in this case, the patient's experiencing a bit of pain on the medial side. So we're going to assess that a little bit further. But before we do, when the knee is slightly bent, it also has a bit of anterior and posterior glide, which we're going to look at next. But I'm going to change the patient's position so you can more easily see what I'm doing. Okay, so as I said, when the knee is flexed, it also has a bit more play in it, especially anterior-posterior. So we can have a look now at a form of an anterior draw test, and this one is called the Ligament test. Place one hand over the thigh and one hand on the posterior part of the lower leg, and then we'll pull the tibia towards us. So we've got this natural gliding going on, and that's an anterior glide test called the Ligament test. There's also another one, and this is called the anterior draw test, which effectively is the same thing, but the knee's typically in a bit more flexion, and grab a hold around the back of the calf muscle there. Place your thumbs over the top of the tibia, over the joint lines, because then you can feel the translation underneath your thumbs. What I mean by that is you can feel the tibia gliding towards you away from the fibula. And that's the anterior draw test. That's easier to do, but the research indicates that the Ligament test is probably a more sensitive test. But there's no harm in doing both, and they are tests for the anterior cruciate ligament, ACL. Next, we can test the collateral ligaments on the side of the knee, and you can perform these tests very simply, and I'll show you how. This is the medial stress test. So I'm going to hold the lower limb just above the ankle. I'm going to stabilise on the outer thigh. I'm going to turn the whole leg into medial rotation, so to kind of lock it and stabilise it in that position. And then I'm going to pull the lower limb towards me whilst making sure I block that movement with my left hand here. And what that does is gap that side of the joint and stress the ligament on that side. That's the medial collateral ligament, the MCL. And you can often see the lower limb pulls away from the knee a little bit, and you can sometimes feel that gapping as the joint opens and closes. That tends to be a bit tighter than the lateral side. So to do the lateral side, we do the opposite. Switch hands, so from the outside to the inside, and again from the inside to the outside. I'll then stabilise the thigh against the side of my hip there, and instead of medial rotation, I'll take the leg out into lateral rotation and stabilise. Okay? And then with a slight flexion in the knee, I want to move the lower limb in whilst stabilising here, so that I'm moving the ankle medially whilst stabilising over the inside of the thigh, and that will cause some gapping of the lateral side and the LCL, lateral collateral ligament. That's often a bit more lax, so it's quite typical to feel that kind of joint opening and closing. That's not unusual when that happens, and that's a ligament which is rarely injured, to be fair. The most common knee injury is the medial collateral ligament. So that was the one that we slight flexion, internal rotation to stabilise and lock in position, stabilise on the outer knee or outer thigh, and then pull the lower limb towards you to stress and gap that inner side of the knee. So those were the ligament stress tests. Next, we're going to have a look at how we can test the meniscal cartilages in the knee, as these are often damaged by forced twisting actions. So for that reason, we can use twisting as our testing. And there's a great test called the Thessaly's test, which we're going to do first, and then we'll follow it up with the McMurray's test as well. I'm going to get a patient to stand on the affected leg, so stand on their right, that's it, and then to slightly unlock the knee, slightly bend the knee, come back up, only ever so slightly, so just slightly bend it, that'll do, brilliant. And I'm holding their arms, as you can see, for support. It's not a balance test, it's not a balance test. And then I'm going to ask them to twist. Good, and twist the other way.
Feel it a little bit. Oh, that hurts a bit.
Okay, and again, not a little bit that way, and yep, you felt it that way, did you?
That way, and both ways actually.
Okay, and down. All right. So aside from the poor balance, which we weren't testing anyway, there was some definite pain with that rotation. Okay, so next we're going to do the McMurray's test to test the meniscus, and we want to combine flexion with rotation in the two directions. So first of all, we'll start with flexion and some lateral rotation of the lower limb, using the foot there as a lever. And then pushing the knee in, we'll start to straighten the knee. Don't have to go all the way, we'll just do that to begin with. How's that feel?
Pain.
No pain there. All right, I'll change my handhold and twist the foot in. Okay, and then again, I'll put a bit of pressure there laterally on the knee and begin to straighten.
No pain there. It's just
No-
I've got weight on.
No
this
pain
as well,
there.
yeah.
Okay, so it's just with weight bearing, which is not unusual, of course. And then if we just backtrack, there was the extension of the knee,
It's okay.
which I thought was a little bit springy. Now, another popular test for the knee, or particularly the patellofemoral joint, is the McConnell test, which is a great test for anterior knee pain. And it's a simple test. There's also another video on the channel, which I'll put a link to at the end, that you can watch. It's one of the popular ones. So if you need reminding of how to do the McConnell test, then that's a great one to have a look at. But as I said, for this test and for the other ones that we've covered, there are some short videos to help remind you should you need to have a quick reference in the future. And I'll put a link on the screen above and put some links at the end of the video as well as down in the description, so you can quickly refer to those in clinic if you need to. Of course, while you're doing all of these tests, don't forget to simply palpate around the knee and identify with the patient where they are feeling the pain. Now, we'll finish off with some resisted tests. All of the resisted tests can easily be performed in prone like so. So put the patient's knee in this position, place your arm around, stabilise on the back of the thigh, and then get your hand over your elbow there so you're in this strong position, and then ask the patient to try and straighten their knee.
Bit of pain there in the knee.
Okay, so they identified a bit of pain with that position on the inner part of the knee. To test resisted flexion, place their leg here and then say, don't let me push your leg down, or push your heel into my hand. Okay, and then for resisted rotations, these can be a bit tricky, so just be clear with your hand placement and that can help the patient. So don't let me push your foot out. Good. And then don't let me push your foot in. Great. And that's how we can test for resisted internal and external rotation. Okay, so if you've got to the end of the video and you're wondering what the diagnosis was, well, from the assessment today, we've had a look at our notes and gone through things, and it seems that it's likely that there's some meniscal derangement in the knee, and that's not unlikely. In fact, with each decade of life, then it becomes more common. So just because there's a potential irregularity in the meniscus, that doesn't mean that the patient needs to go for surgery, and we can avoid kind of digressing into that too much, but surgery is often not a quick fix for an issue that is quite minor for this patient in this case. It's got a very minimal impact on their life, and we've determined that from those earlier questions that we've asked. So at the moment, the plan of action is to reassure, to continue with activity, you know, for well-being, for strength, and for general health as well. Maybe to look at adding in some specific strength and conditioning, because although the patient is fit, if their knee's troubling them, there's likely to be a habitual offloading of the knee. So giving them some targeted knee strengthening will just make sure that the muscles don't do less work and start to atrophy around the knee as compensatory patterns come into play. So a bit of specific knee strengthening, but otherwise a big focus on just keeping active, not being too concerned, reassurance, and then the ability to come back and have some reassessment if it does become more problematic, because of course things always change. It may settle down, it may stay the same for a while, but if it does worsen and start to affect sleep and activity much more so, then the patient would definitely need a review and at the right time, possibly some imaging or something like that. But we don't need to go diving down that route at the moment, because as you saw, the knee had really good range of motion. So we're not looking at a really arthritic knee that's very stiff. And we know that the patient is very active as well. So the last thing we want to do is to try and intervene too much and make the situation worse by trying to make it better. And what I mean by that is having unnecessary scans and unnecessary, possibly unnecessary surgical procedures, all the while making the patient concerned and anxious and reduce their activity. All these things can really set up a downward spiral of function and physical confidence as well. So from a physiotherapy, physical therapy, in my point of view, it's about reassurance and keeping the patient active and giving them some guided focus strengthening that might just give them some extra benefit. And maybe some passive treatments along the way, some simple interventions like massage mediums, whether it's hands, tools, cups, that sort of thing. And the patient is already a keen user of tape for a foot problem, which helps to reduce those symptoms. So maybe occasionally a bit of tape might be something that's useful. But it's really about getting the patient to feel confident that they can keep going and not feel that they need to rely on unnecessary medical interventions or care, for example. So anyway, I hope that helps, and that was my opinion on that assessment, and just to give you some guidance on what I would do. We're not going to do the treatment in this video, we're going to go and do the treatment separately, but I will pop up in the near future another video of some knee treatment to give you some ideas of the sort of things that I would do, which you may find helpful. So that's a quick video on how to assess the knee. I hope it was helpful. Please hit the like button if it was, and have a look at the other videos on the channel which should be showing on the screen here, but there's plenty more as well. If you haven't, then please do subscribe, and hopefully we'll see you again soon.